go to the second talk, Evaluation of Secondary Glaucomas by Dr. Sharmila.
Thank you very much, Subhashini, and I thank a few of you who have found the way to this auditorium. I know it was a complex way. Anyways, this is going to be the 12 minutes I'm going to be talking about evaluation of glaucomas associated with posterior segment disorders. So we heard Veni telling about a lot of causes that might lead to glaucoma secondary to a posterior segment disorder. So let me just take you to the journey of how to unravel this mystery. So number one tip which I would like to give is, whenever a patient walks into your room, you have to start from there. So first, look at the patient, listen to the patient, and then speak to the patient. Most of the information you can get with just looking, listening, and speaking. So number one, when you look at the patient, when the presentation is unilateral, you have a number of conditions that present unilaterally, like the neovascular glaucoma, the uveitic glaucoma, any history of trauma, pupillary block, etc. And those which happen bilaterally, secondary to an ocular ischemic syndrome, nanophthalmic eyes, or any steroid response. So looking at this, you get some information. Next, you have to listen to how they present it. So ask, what is the first presenting symptom? Was it a decreased vision? Was it a pain? Was it raised IOP, which is a sign that you're going to elicit? Look at the anterior chamber depth. Look for any shallow or deeper anterior chamber, because a lot of this will give you an information as to what is the type of glaucoma that you're dealing with and how you're going to treat it. So sometimes the patients may be presenting to your clinic as the first presentation before you diagnose a posterior segment pathology. And then speak. Ask a lot of history. Probe into the patient's history. Look, ask, and speak. So basically, you look at the condition, ask for systemic illness. What is the systemic condition? Whether they are having diabetes mellitus, how often they've been on treatment, how long they've been on treatment. Look for ask for history of hypertension, any history of any infective disorders, and also ask for any history of any treatment for any malignancy. So a lot of information you can get by just getting the history. Next important thing is medication history. You'll also have to look at all of the medicines that the patient is taking. Sometimes they may be having a skin disorder where they may be using steroids or maybe a rheumatoid arthritis. So look at the history and then take very careful history regarding the oral steroid, use of any intravitreal injections previously. So all of this has to be noted very clearly. And then most important thing is surgical history. We all know that most of our retinal surgeons, they often keep sending patients to us. Most of these reason is because of the glaucomas that are associated following a vitreoretinal procedure. So any known posterior segment disease with a history of vitreoretinal surgery, like it could be just an injection, it could be a panretinal photocoagulation, it could be a scleral buccal surgery, it could be a gas or an oil which is inside the eye, and that might be causing a secondary glaucoma. So basic evaluation. The other thing is a basic evaluation. So look at a complete comprehensive evaluation. So aim at that. Number one is best corrected visual acuity. Most often you get a good clue as to what is the diagnosis based on the visual acuity itself. So there may be patients who were very good 6/6 earlier and they just come with sudden loss of vision. So sudden loss of vision could be a vitreous hemorrhage, could be an ischemic optic neuropathy. So you have to understand that these are the two things that can be commonly presenting with poor vision. And very carefully examine the anterior segment. And most importantly, look at the iris for a lot of details. Look for presence of neovascularization. Pupillary reactions, very, very important. See the pupil reaction, whether it is brisk, whether there is a relative afferent pupillary defect, whether it is fixed. And all of this will give you a clue as to what is the condition that you're dealing with. And one other thing which goes without saying is careful examination of the anterior chamber. I think 50% of the diagnosis you can clinch with this. So look at the anterior chamber, see whether it is a normal depth or it's a shallow chamber. Because normal depth, it can happen in many other conditions like posterior segment disorders which have undergone surgeries, like presence of silicone oil, any hyphema, trauma, ghost cells in the anterior chamber, presence of cells or pigments. And shallow chambers is because of any pupillary block. That could be because of a silicone oil, any nanophthalmic eye, or chronic NVG or a uveitic condition. And also examine the anterior chamber for contents. So look for the presence of cells, look for the presence of blood, look for presence of silicone oil, how they present. It's usually an inverse hypopyon that you see, like what is seen here. Sometimes they may be like retained lens fragments and other things. And now going on to the examination. No examination is complete without you doing a gonioscopy or a intraocular pressure assessment. So intraocular pressure assessment, again, whether it is low or high, that might give you a clue as to what is the diagnosis. And very, very important investigation, which is indispensable, is a gonioscopic evaluation in these eyes, because we are dealing with posterior segment disorders where you see a lot of neovascularization that can be seen, particularly in the angles. And carefully examine the fundus. And additionally, we might have to also look for other investigations. We might have to rely on B-scan and UBM, because many times we might not be able to see the posterior segment because of poor visibility, because of vitreous hemorrhage or any blood that is present. So such conditions, you have to rely on B-scan. And sometimes you might also have to look at the UBM to find out the pupillary block, presence of any cyclodialysis or any hidden malignancy in the ciliary body. So neovascular glaucoma, we all know. So I'm going to be just talking about few common conditions and how you evaluate it. So neovascular glaucoma, we all know it's a very, very common presentation which developed glaucoma, and this is basically because of an ischemia. So whenever there is ischemia, we have to keep very important look for neovascularization in the angle, in the iris, and also look for the relative afferent pupillary defect. So presentation of the fundus will give you a clue as to what is the type of neovascular glaucoma that is happening, whether it is because of a diabetic retinopathy, whether it is because of a vein occlusion or an ocular ischemic syndrome. So previous speaker has also told a lot about the neovascularization. Only thing I would like to emphasize here is look at neovascularization at a very high magnification, because very often there will be very fine small vessels which will be missed with just a simple one-time examination. You have to put it at a higher magnification to carefully look at the neovascularization. Also look at the angle for the presence of anterior synechiae or a neovascularization which is present in the angle. So other investigations which have to be definitely done when you see a neovascularization is look for the blood sugar, lipid profile, HbA1c, serum homocysteine, protein C or S deficiencies, fundus fluorescein angiography, retinal OCT to rule out any associated macular edema, B-scan if you're not able to see the fundus, vitreous hemorrhage will be picked up by B-scan, carotid Doppler. Yes, it's very, very important to see the blood flow of the carotid arteries, and so this will give you a clue as to what you're dealing with. Now we move on to the other common entity, which my previous speaker also said, like glaucomas that follow a vitreoretinal procedure. So we often get referrals from the retina clinic following a vitreoretinal procedure. It could be because of a tight buccal, it could be because of retained silicone oil which is not removed, it could be because of gas, intravitreal injections, and even after a PRP. So this is accounting for around 1 to 4% of glaucomas that we see. So intraocular pressure definitely is very high in all of these patients, and many of them even present as an angle closure. So what here we have to look at is look at the eye. Sometimes we might have to see how the buccal is, whether it is a tight encircling band, high scleral buccal. All of this might be a risk factor for an angle closure glaucoma. Look at the presence of silicone oil. So it can present either as an open angle or it could present as a pupillary blocker. So carefully examine this to understand what will be the nature of treatment that you're going to be targeting. And now we move on to the uveitic glaucomas. So we all know uveitis also is a very common entity, and you have to again look at certain features which might be very, very clear cut for uveitis, and they may present as secondary open angle glaucoma, angle closure, or even present with a pupillary block. So key is examine the anterior chamber carefully and also do a gonioscopy to understand what is the nature of the angle closure that you're dealing with. And importantly, you can also pick up other associated signs with uveitis when you carefully examine the slit lamp. Look for KPs, look for cells and flare, look for nodules, posterior synechiae, complicated cataract, and PAS. And in uveitis, not always you will have high intraocular pressure. You may also have patients who present with low intraocular pressure because of ciliary shutdown. So carefully look at the intraocular pressure also and do not rule out the possibility of underlying uveitis. And of course, other associated fundus findings along with uveitis. And when you know it is something you're dealing with uveitis, you have to do a complete workout for a uveitic profile. So basically, you do all the investigations that will clinch the diagnosis as to the cause of uveitis, like HLA-B27, VDRL, TB profile, sarcoidosis, and even sometimes we might have to do an aqueous humor tap to look at the microscopy and culture. Now we move on to the other common entity, which is glaucomas that occur secondary to a ocular trauma. We do see patients who present like this with hyphema, with prolapse of iris, and so you have to understand what is the nature of trauma. So probe into the history, understand the nature of trauma, and always document the visual acuity, because most of these patients are medical legal cases. So you have to document the vision, and also look at the pupils for RAPD. And looking at the pupil itself will give you a clue as to whether it is a trauma. Sometimes patients deny a history of trauma, but looking at the pupil, asymmetry between the pupil, any presence of sphincter tear or traumatic mydriasis, all of this will give you a clue as to the traumatic glaucoma. And you have various types of presentation which happen with any case of trauma, and that will also give you a clue as to how to manage these patients. So again, trauma also, you can see patients presenting with low intraocular pressure or high intraocular pressure. One single indispensable tool for clinching a diagnosis is gonioscopy. You look at the gonioscopy, you find out there is an angle recession. Sometimes you even often see a cyclodialysis cleft or even a hidden foreign body inside the eye. Other investigations which are very important in a case of trauma is B-scan, UBM, and also a presence of any foreign body which is picked up by X-ray CT, and look for any associated damage. Now, nanophthalmos, as previously Vinny had mentioned, she has mentioned quite a lot about nanophthalmos. So basically, I just want to emphasize that they present bilaterally, and they have typical features of a very, very short eye. And carefully look at all the features for that eye, and then do a gonioscopy. You get a clue that it is an angle closure and it is bilateral. Fundus, of course, has typical features of hyperopic disc, ILM folds, foveal hypoplasia, etc. And one important tool is IOL master, because it gives all of the information as to how to diagnose a nanophthalmic eye. You get axial length, you get lens thickness, you get the CCT, you get the RCS by the B-scan, and sometimes you might have to do an ASOCT to decide on the laser PI. There may be other conditions that can cause glaucoma, like glaucoma secondary to an ocular tumor. It could be an open angle or a closed angle. Again, depending upon the intraocular pressure and neovascularization, which may happen very late, and even in gonioscopy, you might have to deal the management. And again, for this, to clinch the diagnosis, you have to do a B-scan, you have to do a UBM to pick up any unknown mass that is present behind the ciliary body. And sometimes we might have to take a FNAC and do some chest X-ray, CT, and PET scan to look for METs. So I would like to conclude by saying that glaucomas secondary to posterior segment disorders are complex entities. They warrant a detailed history and clinical evaluation to clinch the appropriate diagnosis and timely management. Most often, it could be the first presentation of a hidden posterior segment pathology. Treatment should be individualized based on the angle status, optic nerve head, and disease severity. It needs multidisciplinary approach in solving this puzzle. So it is a team effort involving multiple departments. Thank you for patient hearing.
Thank you, Dr. Sharmila. So she has emphasized on how a systematic evaluation helps in